Hello and welcome to TiCME, Time Critical Medical Education. My name's Dr. Nick Taylor and I'm an emergency physician based at the Canberra Hospital. Today's session is one of the TiCME Plus tutorials, so slightly more advanced content, and it's all about wide complex tachycardias. This pairs with the narrow complex tachycardia talk. Remember, if at any stage you want more time to look at any ECGs, just press pause on the movie. So let's just start with a very common scenario in emergency. A 65-year-old man comes in by ambulance with palpitations and complaining of dizziness. The ambulance then say, "We've printed out a rhythm strip," and they hand it to you, and unfortunately you're not quite sure what the strip shows. You're not sure whether you need to act now, and you want to know, how do I work out what's going on? Well, hopefully at the end of today's tutorial you'll have a lot more information on which to base decision making around wide complex tachycardias. The initial approach to any tachyarrhythmia is the same. Is the patient stable or unstable? Are the QRS complexes wide or narrow? And is the rhythm regular or irregular? Remember, first things first, if the patient is unstable and you believe that the cause of the instability is their tachyarrhythmia, think cardioversion first and diagnosis second. Next step is to decide whether it's wide complex or narrow complex, and we're going to talk all about wide complex tachycardias today. Okay, before we get into the detail of wide complex tachycardias, I just want to talk about how we work out the difference between wide and narrows, and to understand the conduction we need a simple smiley dog face picture of the conduction system of the heart. Just to refresh, narrow complex tachycardias are formed when the signal is generated around the AV node in the atria or in the sinus node, and then that signal is conducted to the ventricles via the AV node and the bundles, the superhighways of conduction. This doesn't take very long to depolarize the ventricle, so you have a narrow complex. Now, wide complex tachycardias can form from when there is a rhythm generated in the ventricles. So if the rhythm starts over here, the ventricles will take a long time to depolarize because we're not using the bundles. This will cause a wide QRS, that's a ventricular rhythm, or any of the supraventricular tachycardias which meet a delay in conduction through the ventricles. For example, a left bundle branch block will take longer to depolarize the ventricles and will be a wide complex tachycardia, or any of the supraventricular arrhythmias which depolarize the ventricle via an accessory pathway, will not use the bundles and will take longer to depolarize the ventricles and will be a wide complex tachycardia. Alright, so let's get into wide complex tachycardias. They're defined as tachycardias with a QRS duration of more than 120 milliseconds, or 3 little squares. As we said, they are either ventricular origin rhythms or supraventricular tachycardias with aberrant conduction pathways. You can classify them as regular or irregular tachycardias. Remember that a regular wide complex tachycardia is VT until proven otherwise. 80% of diagnoses made in electrophysiology studies are VT if it's wide complex tachycardia, and remember that you're far more likely to have VT if you're more than 50 and you're a male, or you have underlying structural heart disease. Remember that a regular wide complex tachycardia is occasionally a supraventricular tachycardia with aberrant conduction, like we said, or an accessory pathway. You can also see wide complex rhythms in some particular drug overdoses, such as sodium channel blocker overdose, in situations such as hypokalemia, or in pacemaker rhythms. Okay, so let's talk about ventricular tachycardia. When we classify ventricular rhythms, we basically use rate as our determinant. So ventricular escape rhythm, or an idioventricular rhythm, has a rate less than 40 beats per minute. and AIVR, or accelerated idioventricular rhythm, has a rate 40 to 110 beats per minute, and VT is classified usually of a rate more than 110 beats per minute. Now, it's uncommon for VT to go much faster than about 200. VT is almost always a reciprocating tachycardia of the ventricle. Let's have a look at this ECG example of an AIVR. What we have is a regular broad complex tachycardia, and the heart rate is 100. This is a very common rhythm in patients who have reperfused an acute myocardial infarction. Classically occurs when you thrombolize a patient and they go into AIVR when they reperfuse. Also occurs in PTCA when the cardiologist balloons a lesion. This is not usually a dangerous rhythm. This is usually a good sign that there's been reperfusion of the ischemic ventricle. Okay, so let's talk about VT now. Now, the important thing that we're going to talk about now is how we determine whether something's VT or not. Now, as I said, 80% of wide complex tachycardias at EP studies are VT, so you could just go with the likelihood of statistics and say that everything wide complex is VT, but if we're going to use a little bit more diagnostic zeal, then we start with the clinical scenario. Remember what I said, if you're an adult male with cardiovascular risk factors, or you have structural heart disease, you're almost certain to have VT when you have a regular WCT. The next things we can do to try and work out whether it's VT or not is using the presence of AV dissociation, looking for concordance, and looking for other morphological features. AV dissociation means that there is no connection between what's happening in the atria and what's happening in the ventricle. When we have a wide complex tachycardia, we can somewhat conversely prove the presence of AV dissociation in the rhythm by looking for evidence of AV association in some of the beats. Because if we see that some of the beats definitely show AV association, we can assume that all the rest of the beats, i.e. most of the rhythm, shows AV dissociation. So we look for evidence of capture beats. Now, capture beats are beats which have been transmitted the normal way from atria to ventricle via the AV node, so they will look like narrow, complex, almost normal beats. We can look for fusion beats, and fusion beats is when a atrial depolarization goes through the AV node and depolarizes at about the same time as their ventricular depolarization, so you get a hybrid beat which isn't quite as wide as one of the ventricular beats. Or we may see P waves buried in the VT rhythm which show no relationship to the QRS complex. So if we see P waves that aren't conducted, we prove again that there's AV dissociation. Okay, so let's look at this little rhythm strip. What we have is a regular broad complex tachycardia. What's interesting is we've also got the sinus node beats and then the rhythm initiates. So we can see what a relatively normal beat looks like. What we've got is two slightly different beats here. One beat is not quite the same as the main thrust of the rhythm, and this is probably going to be a fusion beat. You can see that there's probably a little P wave just before it, so this is one where a P wave snuck through but initiated the ventricular rhythm at the same time, so this is probably a fusion beat. And here's a much more narrow, complex, normal looking beat, which may well be a capture beat where a normal sinus beat has snuck through the AV node. We don't see any evidence of non-conducted P waves in this strip, but these two beats, which show some form of AV association, prove the AV dissociation of the rest of this rhythm strip, and thus that this is VT. The next feature on ECG is concordance. Now, concordance means that the QRS vector is either all positive or all negative in the chest leads. Let's look at an example. So here's a wide complex regular tachycardia. If we have a look in the chest leads, so V1 through to V6, all the vectors are basically dominant upwards, so terminal R waves dominate. And this is called positive concordance. So this would suggest that it's more likely that this rhythm is VT. So what else is there? Well, there's lots of morphological features which become very complex. Some of the more simple ones include the QRS width. So if you have a right bundle branch morphology ECG with the QRS duration greater than 140 milliseconds, it's suggestive of VT. If you have a left bundle branch pattern with a QRS duration more than 160 milliseconds, it suggests VT. If you have a right superior axis, it suggests VT. And there's lots of other morphological criteria, lots of information available on other web tutorials. I find that these morphology criteria are less easy to remember in the heat of the moment, so it's more for academic interest. So we've talked about VT. Now the next group of wide complex tachycardias we need to talk about are the supraventricular tachycardias which have aberrant conduction. So there are two groups. Firstly, there is SVT from any cause which has an intraventricular conduction delay. So there is delay within conduction in the ventricle, and commonly you get a typical left bundle branch block or a typical right bundle branch block manifesting in the ECG. The second group are those patients who have an abnormal accessory pathway from atria to ventricle. And this shows you wide complexes because the ventricle gets depolarized early and from not via the AV node. And you can look for a much higher rate than you normally expect, and if you have a normal ECG you should see evidence of pre-excitation. So that's the short PR interval and the delta wave. Okay, so let's look at our first wide complex tachycardia ECG example that might be SVT with aberrancy. When we look at this ECG, this is an ambulance ECG, we see a regular wide complex rhythm. Now, this could be VT or this could be SVT with aberrant conduction. How are we going to work it out? We start with, remember, the clinical scenario. Now, this patient at the time was sitting up and talking and wasn't symptomatic. That gives us slightly more indication this may not be VT, but plenty of people do have asymptomatic VT runs. The next question is, has this got any definite features for VT morphologically? Well, we don't see evidence of capture or fusion beats or even unconducted P waves in this rhythm strip, so we don't see classic evidence of VT with AV dissociation, but that's not everything. We do see a bit of negative concordance, but there are R waves in V6, so this isn't true negative concordance. Remember, if we have a wide complex rhythm, you should look to see whether it's a classic left or right bundle branch block. Now, this looks like a left bundle branch block because we have deep S waves in the septal leads with upright T waves and terminal dominant R waves in the lateral leads with inverted T waves. Remember that if the left bundle is greater than 160 milliseconds or 4 little squares, it's more likely to be VT. This is actually just on 3 little squares, slightly against VT again. The other thing is the rate. Now I know you can't see the boxes here, but this rate is exactly 150 beats per minute. Remember what I said, if you see 150 beats per minute, always think atrial flutter. So at this stage, I think the differential diagnosis is VT or flutter with a left bundle branch block. How do we tell? Well, the only real way to tell is what the normal ECG looks like. So luckily we got one, and you can see that the sinus rhythm ECG again shows a left bundle branch block. How do I know that this patient was predisposed towards flutter or fib? Well, again, bit lucky, year before had come in atrial fibrillation, a irregular wide complex tachycardia here, but again showing typical left bundle branch block. So fairly comfortable now to diagnose that first ECG as atrial flutter with 2-to-1 block and a left bundle branch block. Okay, so let's have a look at this next example of supraventricular tachycardia with aberrant ventricular conduction. Now, looking at this ECG, a bit scary to start with, very fast, about 280 beats per minute, broad, regular, no obvious capture or fusion beats. Looking at the morphology, it does look reasonably typical of a left bundle branch block. There's deep S waves with upright T waves in the septal leads. There's terminal dominant R waves with inverted T waves in the lateral lead. This child was 3 or 4 weeks old and presented after being completely healthy its whole life with normal postnatal checks with 3 days of obvious fatigue and decreased feeding. Now, why isn't this VT? Well, it might be, and sometimes determining whether it's VT or SVT with aberrancy at the time is impossible. This child actually presented in left ventricular failure with crackles in its lung fields and desaturating. It was only when we sent it off to Westmead Hospital that, with all the subsequent tests being normal, that it was proved to be SVT with aberrant conduction. Now, in terms of likelihood, a completely normal child who was well up until that point, who goes into a very fast rhythm, is almost always going to be SVT, not VT. Now, how does this become broad though? Because SVT should be narrow. Well, it turns out that the left bundle can't tolerate the very high rates that it's been asked to conduct at for a long period of time, so it fatigues and develops a rate-dependent left bundle branch block. Obviously, the child's left ventricle fatigued as well, because the child was in acute left ventricular failure on arrival. This rhythm was actually resistant to adenosine and required a DC cardioversion for termination. But it was very good that the progress report 2 days later, the child was completely well with a completely normal echo, and the diagnosis was paroxysmal AVRT. Okay, let's look at our next broad complex tachycardia. Again, what we have here is a wide complex regular tachycardia. Remember what we have to ask ourselves in the rhythm strip: are there any evidence that there's capture or fusion beats? The answer is no. Is there any evidence that this has got P waves that are unconducted? Hard to be sure. Might be that you suggest that there may be some P waves here. Thinking back to our supraventricular tachycardia talk, these do look a little bit like pseudo S waves. So that's something to remember. Pseudo S waves can make you think of a short RP tachycardia. But let's go back to the broad complexes. Are these typical of a left or right bundle branch block? Certainly don't look like a left bundle branch block, but we have an RSR prime complex in V1 and V2 with inverted T waves, which would suggest that this is a right bundle branch block type of pattern. So the other thing to look at, remember, is rate. Now you can see that this is exceedingly quick. It's probably about 190-200 beats per minute. Now that, as we say, is often too fast for VT. The only thing though that's going to make us really certain is what is the clinical scenario and how does this patient respond to treatment. Well, this patient was actually 25 years old and is asymptomatic in this rhythm. Again, that makes it slightly less likely this is going to be VT. It's interesting that there are two differential diagnoses though. The first is that this is an SVT, a paroxysmal SVT like AVNRT with a rate-dependent right bundle branch block. Now, that could be the case because remember what we saw, these pseudo-F waves, so that could be a short RP tachycardia. The other possibility is one that we haven't mentioned this, and this is a fascicular VT, with the commonest type of fascicular VT being a posterior fascicle VT, which gives you a classic right bundle branch pattern. Now classically that actually responsive to verapamil, and it's otherwise known as a verapamil responsive VT. How are we going to tell the difference? Well, in fact, it's going to be impossible without the aid of EP studies. This patient was given adenosine and reverted to normal sinus rhythm without a right bundle branch block but when they went to EP studies, it was determined that they actually had an AVNRT, so a paroxysmal SVT with a rate-dependent right bundle branch block. But this ECG could either be VT, although the morphological features would suggest against VT and the clinical scenario, paroxysmal SVT with right bundle branch block, which it was, or a fascicular VT, or verapamil responsive VT. Okay, let's look at our next ECG. This is again an ambulance ECG showing a broad complex rapid tachycardia. Now again, the rate is very high. The rate is something over 200 beats per minute here. It's probably about 220 beats per minute. The next question is, are there signs of AV dissociation? And if we have a look here, we don't see any obvious capture or fusion beats, and we don't see any obvious P waves that are non-conducted, so we can't prove AV dissociation. Is there any concordance? Well, there isn't. There's predominantly positive R waves in V4 to V6, and these are very deep S waves, although they're hard to see in V1 to V3, so there's no concordance. Is this a classic left or right bundle branch block pattern? It's not absolutely classic, but certainly there are features to suggest a left bundle type pattern. We have got terminal R waves in lead 1 and lead V6, and we've got deep S waves, upright T waves in the septal leads. In fact, this patient, again, it's going to be important to use your clinical nous to try and work out what it is. This was again a young person. He was a 19-year-old. He was feeling a little bit dizzy, but otherwise all right. He didn't have a diagnosis of structural heart disease and had been usually fit and well. In fact, the ambulance gave this man adenosine, which was, I think, a little bit brave in the context of being in the back of an ambulance, but he reverted to sinus rhythm. Now, his sinus rhythm ECG showed short PR interval and a delta wave. So this man actually has an antidromic AVRT. Again, to summarise, morphologically there's no evidence of AV dissociation, there's no concordance, it's very fast, in fact faster than we'd normally expect VT to be, and it reverted with adenosine, which VT shouldn't. The wide complexes, just to summarise, can be because of the antidromic transmission, which is the usual in Wolff-Parkinson-White. But again, like we saw in the neonate, it can be because you get left bundle fatigue in an SVT, or it could be that this patient had a pre-existing left bundle branch block and went into an AV-NRT, for example. Again, the resting ECG proved that this patient had Wolff-Parkinson-White, and EP studies proved that this is an antidromic AVRT. Just going to go back over the accessory pathway transmission physiology again. So remember, a patient with an accessory pathway and Wolff-Parkinson-White in sinus rhythm has the transmission going down the AV node and also down the accessory pathway. The depolarization takes a quicker time via the accessory pathway because it's not slowed down by the AV node. The ventricle therefore depolarizes early, giving a short PR interval, and starts depolarizing from out wide, so you get the slurred upstroke delta wave and a wider QRS complex than normal. In orthodromic AVRT, which is narrow complex, you go down the AV node and re-enter via the accessory pathway. And in antidromic AVRT, like we saw in the last example, the patient depolarizes and then enters the ventricle via the accessory pathway and re-enters via the AV node. Remember, this is more dangerous because the accessory pathway does not have the inherent properties of the AV node to slow conduction. So antidromic AVRT. To summarise regular wide complex tachycardia, most regular wide complex tachycardia is VT, particularly if age is more than 50, the structural heart disease or typical features on ECG. You can next have an SVT of any description with aberrant conduction, and remember, it makes it easier if you see a typical left bundle or right bundle branch block and that left or right bundle is seen on the resting ECG. And the other possibility, there is an accessory pathway seen in conditions like Wolff-Parkinson-White disease, and often these rhythms are very fast because the depolarization is occurring via that accessory pathway. Alright, so now we move on to irregular wide complex tachycardia. And in irregular wide complex tachycardia, there's really three main options: VF, polymorphic ventricular tachycardia, or atrial fibrillation with aberrant conduction. This is the ECG that basically should never be done, and it's not hard to see that there is a very chaotic looking baseline. There is no formed QRS complexes. The rhythm is irregular, so this is ventricular fibrillation or VF. VF is never a stable rhythm. It's formed because there are rapid, uncoordinated, ineffective ventricular contractions from chaotic electrical activation in the ventricle. Common causes include ischemia and electrolyte disturbances, but by far the most common cause of VF in our community are people having VF as the first manifestation of their acute myocardial infarction. So you shouldn't try and think about the cause, and you should actually cardiovert them. Next we go into polymorphic ventricular tachycardia. There are two main types. There's the classic that you've all heard of called torsade de pointe, and that is a polymorphic VT which is preceded by a long QT corrected. The next sort is standard polymorphic VT, and that is defined as PVT without preceding long QT. If we have a look at this rhythm here, we have got someone who is banging along in sinus rhythm before suddenly entering a rapid, broad, irregular and polymorphic rhythm. Question is this torsade de pointe or is this polymorphic VT? Now luckily we have got a rhythm strip. The QTC doesn't look like it's going to be more than halfway between the R waves, so the end of the T wave is less than halfway between the R waves, and that would tell us the QTC is likely to be less than 500 milliseconds. So this is polymorphic VT, not likely to be torsade de pointe. The treatment is immediate cardioversion. Now here we have again a nice little ECG where we have a preceding couple of beats with an ectopic or two, followed by a wide complex irregular rhythm where the axis appear to be regularly changing. Now if we have a look at these preceding beats, particularly this sinus beat, you can see that the T wave is very, very late. Here again the T wave very, very late. So these T waves are finishing well past the 50% between RR distance. So there's a long QT interval here which then generates this rhythm. And again, when we terminate our rhythm, you can see just how long the QT interval is. The T wave is finishing almost on the back of the next QRS complex. So this is classic torsade de pointe. Not only is there a twisting of the points, but there is also a long QT interval. Now the treatment of this rhythm is magnesium sulfate and cardioversion. Cardioversion by itself is unlikely to be successful unless you use magnesium in the long QT induced torsade de pointe. Alright, so let's look at the next example of an irregular broad complex tachycardia. This one's a fair bit easier. Now remember, polymorphic VT, the QRS complexes really aren't very well formed. Each of the QRS complexes looks a bit different, hence the polymorphic. Here we have an irregular broad complex tachycardia, but the QRS complexes look the same. Now it is definitely irregular, so we can be fairly comfortable that it isn't VT. So now we're looking for classic left or right bundle branch block features, and I think you'll agree that with dominant terminal R waves and deep S waves, we've got a left bundle branch block. So we've got an irregular rhythm with a left bundle branch block. Are there evidence of P waves? Doesn't appear to be. So an irregular rhythm with a left bundle branch block is almost certainly going to be atrial fibrillation. Obviously this will be proven if you go into sinus and you'll have the left bundle branch block in your sinus rhythm ECG. So remember, with AF with aberrant conduction, you're going to normally have a typical right or typical left bundle branch block giving the broad complexes. Okay, so here's another irregular broad complex tachycardia. Now this is probably the most important one for today, because this ECG, if you diagnose it correctly, can save lives. Now let's look at our baseline. We have an irregular broad complex rhythm. Now remember that most irregular rhythms without P waves, and I think you'll agree there's no obvious P waves in here, are AF, particularly if the baseline doesn't have an isoelectric period, and again doesn't look like we've got an isoelectric period in our baseline. So this, again, we could say could be AF with aberrant conduction. Now the question is this AF with a left or right bundle branch block, or is this something else? There's really only one key feature of this ECG that you need to understand, and that is that in a typical left or right bundle branch block, the morphology of each beat in the same lead will look the same. Can you see evidence of that here? I think you'll probably agree that there are different morphology QRS complexes in each lead. How could that be the case if there's a fixed left or right bundle branch block? That should make us suspicious, and it does. The only way that we can get different morphology in the same lead is if there are different pathways of conduction to the ventricle. It's very unusual that you'll have a varying bundle branch block. So if we remember back to our accessory pathways, if we have a rhythm in the atria, that signal can be delivered via the AV node or via the accessory pathway. Now, just the same way that you can get fusion beats in VT, it's likely that in this scenario there is a broad beat where the signal has come via the accessory pathway, and it's probably a left accessory pathway because we're getting a right bundle branch block type of beat here. Then we have a more normal narrow looking beat, and this is probably because the atrial depolarization has made it through the AV node and the accessory pathway at the same time. And then we have another more normal looking beat followed by broad beats again. So this is a patient with Wolff-Parkinson-White and atrial fibrillation. Now why is it so important? Well, it's so important because atrial fibrillation, remember the atria is fibrillating at up to 300 to 600 beats per minute. The presence of the AV node in the conduction pathway can slow conduction through to the ventricle and allow the ventricular rate to be relatively controlled. If we completely block the AV node, then there can be one-to-one conduction of the atrial rhythm through to the ventricle, and that would give us basically a polymorphic VT looking picture. It's actually a atrioventricular rhythm, but because the signals are all very chaotic and very rapid, the QRS complexes would be poorly formed and they would look like polymorphic VT. That would be a very dangerous rhythm to be in. So again, the morphology of AF in Wolff-Parkinson-White with antidromic conduction down the accessory pathway is there is beat-to-beat variation in morphology. There's presence of fusion beats. There is even a capture beat here. See the P wave, and the QRS complex has been captured, and then we see pre-excitation. So there's delta waves in the ECG, which is showing us that there's ventricular pre-excitation. So this is very concerning if we don't pick it up, because if you give a large dose of AV nodal blocking drug to this patient, you can make them far worse. To summarise, antidromic Wolff-Parkinson-White confers the risk of one-to-one transmission of the atrial rhythm through to the ventricles, particularly in the presence of AV nodal blocking drugs such as verapamil. What will happen? Well, you get a polymorphic VT-like picture. Actually, it's actually an atrioventricular rhythm, but particularly if it's AF, you're going to get a very rapid, very chaotic ventricular rhythm. Here's someone going into that rhythm with a DC cardioversion. Now, this was a 19-year-old who came in with AF and Wolff-Parkinson-White and syncope at home. It was deemed, and was very sensibly deemed, that cardioverting with electricity was a safer option than chemical cardioversion. Probably in retrospect, we should have given him more than 70 joules for his first shock, because what happened is probably we managed to block the AV node with the cardioversion but not the accessory pathway. So how he goes into this horrible broad complex chaotic rhythm, which is essentially atrioventricular fibrillation. We had our wits about us, which was lucky. So we turned sync off, because obviously we're going to do an unsynchronized shock now, charged up to 200 joules and successfully cardioverting him back into sinus rhythm. Phew. Clearly, you could think of a situation where you gave someone a larger dose of verapamil for their AF, the patient didn't have access to a defibrillator and they went into that rhythm. Wouldn't last very long. Very scary. So to summarise, irregular wide complex tachycardias. VF is broad, irregular, with no baseline and no QRS complexes. You should all be able to pick that. Polymorphic VT has typical morphology. If it's preceded by a long QT and has twisting axis, it's called torsade de pointe. Otherwise, it's just polymorphic VT. You can have AF with aberrant conduction, and remember that within the same lead, the QRS morphology will look the same. And then we can have AF in Wolff-Parkinson-White with an accessory pathway, and the QRS morphology will differ within the lead. And we may also see capture and fusion beats, which suggest that there are two pathways to the ventricle. Okay, to finish off wide complex rhythms, I'm just going to show you a few of the more interesting variations. Let's look at this rhythm strip. It's broad. It's not particularly fast. It's around 100 beats per minute, slightly less than 100, probably about 95 beats per minute. Remember, that's not classic for VT. Also, there aren't any formed QRS complexes, so we don't think there's going to be a bundle branch block. Does anyone know what this is? Yeah, this is absolutely classic for life-threatening hyperkalemia. This is just before you get a true sine wave. The interesting physiology point of hyperkalemia is that it's not ventricular tachycardia usually in hyperkalemia, although you can have VT provoked. The normal rhythm you get as you progress is actually a sinoventricular rhythm with such impaired conduction due to the hyperkalemia that you get these horrible broad complexes. Therefore, the treatment of life-threatening hyperkalemia is not with DC cardioversion of this rhythm, because it's unlikely to be successful, because this is the sinoventricular rhythm. The sinus node is actually quite resistant to the effects of hyperkalemia, but you do need to immediately treat with intravenous calcium, with insulin and dextrose, and in a situation which is this unwell, I would probably also give some bicarbonate as well. So remember that the wide complex rhythm in hyperkalemia, especially when it's going at this relatively slow rate here, is a sinoventricular rhythm, and the treatment is reversing immediately the hyperkalemia because it's unlikely to be fixed by cardioverting the patient. Alright, now let's have a look at this next broad complex rhythm. As a standalone rhythm, it's going to be contextual to make the diagnosis. So if I told you this is a 27-year-old person who's taken a propranolol overdose, it should help you to work out what's going on. Now, basically, propranolol doesn't really work like a beta blocker in overdose. It works like a sodium channel blocker. Sodium channel blockers cause widening of the QRS, and one of the diagnostic features, particularly one that predicts for becoming unwell, is a dominant R wave in AVR. That's a good little trick. Usually there's an S wave in AVR. Once you start getting an R wave that is a greater height than the S wave in AVR, you should be concerned in the context of a sodium channel blocking overdose. Now this is all R wave and no S wave, and a very broad QRS complex. Some of the other features of sodium channel blockade that are concerning are a QRS width greater than 160. So this is actually a classic ECG for a sodium channel blocking overdose. Treatment is bicarbonate therapy, and if the patient was to arrest, you really need to just give them 100 millimoles of bicarbonate every 2 minutes until you get return of circulation. We're not going to talk in detail about sodium channel blocking overdose, but you can get a broad complex rhythm secondary to sodium channel blocking drugs. From a physiology perspective, if you remember our cardiac action potential, blocking the sodium channels causing a delay in inflow of the sodium, so therefore it takes longer to depolarize, and that widens the QRS complex. In the setting of a potassium blocker, you get delay in K plus E flux, which causes the T wave to be later and increases the QT interval. What about this? Is this a wide complex tachycardia? Well, it is a bit fast, but this is actually sinus rhythm, and this is lead 2, and what we've got is massive ST elevation. So this is mimicking a wide complex tachycardia. This is actually someone having a right coronary artery ST elevation, myocardial infarction, so it's mimicking a WCT. Obviously, if you had the full 12-lead ECG, it would be much more obvious, but that'd be a bit of a shame to make that mistake. I'm just including this pacemaker rhythm here as a bit of interest. This is an example of a pacemaker mediated tachycardia. You won't see this very often. Essentially, with a dual chamber pacemaker, you can get a reentrant pathway using the atrial and ventricular leads as a reentrant circuit. One of the giveaways is that the rate is exactly 125, which is commonly the highest set rate for a pacemaker, and so this is a person who was just flicking in and out of this rhythm rapidly, and it turned out to be a pacemaker mediated tachycardia. One of the other possibilities is atrial flutter in a pacemaker patient. Here's another example of a broad complex rhythm. We were quite lucky to get this as a 12-lead ECG. Some people who have pacing defibrillators have obviously got different modes which terminate their arrhythmia. Usually pacemaker defibrillators don't deliver a shock for VT initially. They'll try to overdrive. So here's a beautiful little ECG example of someone initiating VT, then having overdrive by the pacemaker, going back into what we hope is not VT. It's probably a sinus rhythm with bigeminy. So VT, pacemaker overdrive, sinus with bigeminy. So final ECG is just one for keep you on your toes. If we had to look at lead 3 or lead AVL, you'd be pretty concerned that this patient may have had a polymorphic VT, for example. It's very fast, it's quite irregular, the complexes look awful and wide. The patient was feeling pretty unwell, which confused one of the people looking after them, thinking, oh, he's having intermittent runs of polymorphic VT, then going back into a normal rhythm. Maybe they've got atrial flutter because there's what looks like a flutter wave here. I think the giveaway, though, is look down at lead 2. Remember to always start with the rhythm strip. We have a regular QRS complexes. If you go up from your QRS complexes, remember this is time, we can see QRS complexes within that other funny looking rhythm. There are definite P waves here, so our underlying rhythm is sinus. This is a shiver artifact from a very cold patient. But you can imagine if you were monitoring the patient on AVL, for example, only, you could get quite confused. It's always important to go and talk to your patient when you see an abnormal rhythm, though, before you leap into action. So to summarise, wide complex tachycardias, if they're regular, then we're going to assume it's VT, but it could be one of the supraventricular tachycardias with aberrant conduction or Wolff-Parkinson-White. If they're irregular, then we have VF, which should be obvious, polymorphic VT, AF with aberrant conduction, or again, Wolff-Parkinson-White. And the other ones which sort of mimic wide complex tachycardias include hyperkalemia, sodium channel blocking drug overdose, and pacemaker rhythms. Back to the schema again. If we have a tachycardia and the patient is unstable, consider emergently shocking them, rapidly treat any electrolyte disturbances, consider toxicological causes. If they're stable, we then go through our wide or narrow complex algorithms. Remember, this links in with the narrow complex tachycardia talk, and we've just discussed the regular differential and the irregular differential. And here is all of the tachycardias combined, wide complex and narrow complex. Remember that all of the narrow complex rhythms, if there's aberrant conduction, can cause a wide complex tachycardia. Thank you very much for listening to Wide Complex Tachycardia. I hope to see you next time on TiCME.